Hello and welcome to ACON's Suicide Prevention Forum, All That We Carry. To begin, we have a message from the New South Wales Minister for Mental Health, the Honourable Rose Jackson.
Hi, I'm Rose, the Minister for Mental Health, and I'd like to begin by acknowledging the traditional custodians of the lands on which we're meeting today. For me, that's the Gadigal people of the Eora Nation. I also pay my respects to elders past, present and emerging, and extend that respect to Aboriginal and Torres Strait Islander people online with us today. It is an honour to welcome you all to today's forum. All That We Carry enables us to have open discussions about the lived experience of people of diverse sexualities and genders on suicide, mental distress, and on getting help. It's an important discussion to have, and it will help identify how our services can be improved. We know that mental, emotional, and situational distress is the most prevailing issue for sexuality and gender diverse communities, due in large part to social isolation and persistent exposure to stigma and discrimination. As part of the New South Wales Health Strategy, the New South Wales Government has made a commitment to increase access to mental health and suicide prevention services and support for people of diverse sexualities and genders. Improving how people can find that support and navigate the range of mental health and suicide prevention services will help reduce the far too many people lost to suicide. Today's forum is one of several initiatives funded by New South Wales Health to focus attention on people of diverse sexualities and genders' lived experience of suicide. New South Wales Health is proud to support ACON to deliver a range of statewide services and programs for sexuality and gender diverse people. These include telehealth crisis and support after a suicide attempt, suicide prevention programs and counselling services for trans and gender diverse communities, a digital suicide hub here for community members and organisations to access key resources and services, the Pride in Health training and mentoring program to support New South Wales Health staff to improve their knowledge and understanding of inclusive care. My thanks to the ACON team for organising today's event and for your wider efforts to address the overrepresentation of people of diverse sexualities and gender amongst New South Wales suicide statistics. Today's forum's participants, thank you for taking the time to take part and share your experiences and insights. This will help us reduce the devastating impact of suicide on our community, on our friends, and on our loved ones.
Thank you, Minister. We would also like to acknowledge the traditional owners and custodians of the lands on which we meet today. For me, I am living and working on Gadigal land. And we collectively pay our respects to elders past and present and any Aboriginal or Torres Strait Islander people here today. We extend our respect and acknowledgement to all sister girls, brother boys, and LGBTQ+ Aboriginal and Torres Strait Islander people. We acknowledge the strength, resilience, and resourcefulness of these communities despite the ongoing colonial structures and policies that remain in place today. Sovereignty was never ceded, always was, always will be Aboriginal land. So I'd like to introduce myself and my co-host today. My name is Sam Rogers. I am the Community Health Promotion Officer of Suicide Prevention Programs at ACON. My pronouns are he and they, and I'm wearing a black t-shirt with a heart pin on my, just above my heart. I have blue eyes and pulled back blonde and gray hair.
And I'm Barbara Stott. I'm a lived experience of suicidality consultant and facilitator. My pronouns are she, her. I'm a tall white woman with short brown hair and green eyes. And today I'm wearing a green shalwar kameez, and I'm coming to you from the lands of the Wurundjeri people of the Kulin Nation.
Thanks, Sam. Today's forum will be approximately 90 minutes long, and we are supporting awareness about LGBTQ+ communities' lived experience of suicide, distress, and navigating care. Our communities have had it really tough over the last few years, and we've lost too many people to suicide. Today, we're gathering to talk about it. The forum is divided into two parts. The first will ground our understanding of experiences of suicide for LGBTQ+ communities in this state and the country. And the second part will be a panel discussion with community members and allies working behind the scenes and on the front line, helping community navigate care. Please use the Q&A function of Zoom for any questions you might have, and we will also endeavour to answer them after the panel. Established in 1985, ACON is now Australia's largest LGBTQ+ health organisation. ACON specialises in community health, inclusion and HIV responses for people of diverse sexualities and genders. ACON provides free or very low cost and confidential counselling, care coordination, peer support, suicide prevention and aftercare services and ageing support services to people living with HIV and their families and LGBTQ+ people. These services are delivered in person in Sydney, Newcastle and Lismore, or via telehealth. ACON has been funded by the New South Wales Government to support the Premier's priority to reduce the suicide rate in New South Wales. We launched here.org.au, an online suicide prevention hub for LGBTQ+ people in New South Wales in November 2022, and our ongoing work are part of New South Wales Health's Towards Zero Suicides initiative, community response packages for priority group. So the here.org.au should be in the chat if you would like to use it, or you can have a look after the forum. We'd also like to acknowledge the lived experiences of suicide. People with lived or living experience of suicide are those who have experienced suicidal thoughts, survived a suicide attempt, cared for someone through a suicidal crisis, or been bereaved by suicide. Without the expertise, insight, generosity, and courage of those with a lived experience of suicide, particularly members of the Rainbow Mental Health Lived Experience Network and any other lived experience network such as Roses in the Ocean and Switchboards work in this area, we could not do that work without our community's contribution and ongoing feedback. We also want to acknowledge the history of stigma, saneism, and criminalization that suicide has had, and the work that many people have done and have been doing on the front lines with the community, and those who have established new alternative care models that affirm our lived experiences.
So we invite all attendees to put their name, their role, and the First Nations country from which they're tuning into the chat. Or I think we're actually going to do that in the Q&A function so that we can pull it all together. We're all here. Considering the sensitivities and diverse lived experiences of suicide and the possible impersonal nature of an online presentation like this, we would like to emphasise, without being glib, that we're all here. We're all here and we strive to lead the following forum acknowledging this. We would like to acknowledge that the content of the forum might bring about distress or be overwhelming, feel overwhelming, and we encourage attendees to take a moment at any time, leave, step out, check in via private message with the ACON support team who are on standby. We'd also like to preface that this forum is educational rather than therapeutic. We won't be sharing personal experiences nor describing how people in our community may have ended their lives. We hope that we've made the forum safe enough for everyone attending. Please take note of the crisis support service lines that are in the chat. I think there might be another slide that's coming. Yes, awesome. Great. Okay. I'm not sure who's operating the slides, but if I could have the next one, please, that would be awesome. Great. Okay, so we're just going to take a minute to talk about language. So we just want to clarify what we're on about when we're talking about suicide and mental health. So I'm going to start with mental health. So that would be the next slide, please. Great, thank you. So mental health is kind of like a picture of a person's mental well-being. It's also affected by social determinants of health like income, housing, early childhood experiences, social exclusion, education level, sanitation, social support, discrimination, stigma, and access to resources. So a whole bunch of different things. Mental well-being is the extent to which a person feels positive and hopeful about their own life, their ability to manage behaviours, feelings, and stress, and the development of critical self-determination, reflection, determination, and autonomy. Mental illness is understood by the biomedical explanatory framework, so doctors, as a way of impacting people's cognition, emotion, and behaviour. So that might take the form of diagnoses, things like depression, anxiety, those sorts of things. And those, from a medical perspective, those are things that can be treated clinically or using medication. Mental distress is when someone has deeply unpleasant feelings or extreme states, symptoms. They may or may not be due to mental illness. So there's kind of like a distinction there. We stress that mental distress and suicidality don't necessarily coincide. So they're actually two different things with some overlap. And then if we can have the next slide, please. So it's important to acknowledge that self-harm is not always indicative of suicidal behaviour, and they might, in fact, again, be two different things. It can be something to take seriously, as the severity or frequency of harm may increase a person's risk of accidental suicide. Self-harm can be used as a way of coping with mental distress without suicidal intent. That brings us to suicidality. So that refers not only to suicide attempts and deaths by suicide, but also to suicidal ideation and planning too. So that's when we've got thoughts in our heads about ending our lives. Ideation can vary in intensity over time, from a passive desire to fall asleep and not wake up, to actively planning ways to end one's life. And the next slide, please. Thank you. So what people think about suicide is often influenced by cultural beliefs, religious beliefs, clinical beliefs, and personal experiences. Suicidality is not always connected to the mental well-being of the person. It's in fact more likely to be in reaction to situational distress, which we'll talk about later. It's not always compulsive. It's okay to talk about. Talking about it won't encourage suicidal behaviours in other people. And suicidality is not someone just seeking attention. This further stigmatises suicide and creates a barrier to support seeking. Suicidal behaviour, according to the interpersonal psychological theory of suicide behaviour, is predicated on feelings of not belonging, feelings of being a burden, and hopelessness. So I'm just going to take you through some current statistics and state-based frameworks relating to suicide prevention, particularly in relation to our community. So this presentation takes its data from the Scoping and Literature Review that ACON created for here.org.au, which in turn used data collected from La Trobe University's Private Lives 3 survey. We go to slide 14, please. Great. Look at all of those things. So if you want to nerd out on the research, get onto those QR codes. So Private Lives 3 contains the most recent data on the lived experiences and specifically mental health and suicidality of LGBTQ plus communities Australia-wide. While Suicide Prevention Australia's State of the States report outlines where gaps in data emerge on a state-by-state basis. So we're kind of looking at a few different things there. And then there's the Australian Institute of Health and Welfare. They have a page on LGBTQ plus communities, which outlines and updates current data. So we've got a few different things there. So then the next slide. Okay, so let's just have a little look at the framework for suicide prevention in New South Wales. So that's from the Suicide Prevention Australia State of the States Report 2023. So it emphasises that lived experience leadership, expertise and insights must be integrated into all aspects of suicide prevention. There are safe spaces and alternatives to emergency departments such as safe havens and suicide prevention outreach teams, and we'll hear about those shortly. There is embedded cultural safety for priority populations, including HETI courses. So that's the Health Education Training Institute. I think I'm always onto the acronyms. Courses for New South Wales health workers on working effectively and inclusively with our communities. And then the next slide, thanks. Awesome. So in terms of gaps in the data, the most glaring reason for a lack of data is the ongoing issue of LGBTQ folk being left out of the ABS, that's the Australian Bureau of Statistics, census data. Not just for determining a more accurate percentage of the LGBTQ plus population who might be experiencing suicidality, but to better help and understand our community's overall health and well-being too. So according to the State of the States, that's a mouthful, isn't it? Data report, data availability for priority populations is lacking due to underreporting of a person's intersecting identities. Emergency department presentations need a standard of reporting that includes more context to a person's suicidality. And an overarching and ongoing impact of LGBTQ plus data is the concern around privacy and confidentiality to share one's diverse gender and or sexuality, especially for people who may experience suicidality because of cisgenderism and heteronormativity prevalent in their lives. And then the next slide. Awesome. So before we discuss the statistics around suicidality for LGBTQ plus communities, it's important to emphasise that while these statistics are helpful to direct funding for services and health promotion, they are not a predetermined reality for us as individuals. The numbers can be overwhelming, but they can also be reassuring. We can see that we're not alone, that there might be more understanding of suicidality in our communities than we might realise, and that finding a network of peers might not be as difficult as we thought. We acknowledge both the reality of ongoing trauma and systemic barriers to care and the resilience and coping skills of people in our community. And for people who work alongside our communities, it's important not to let a statistic get in the way of listening to people's individual and unique stories and specific support needs. Always believe that the human person you're talking to more than a stat about the kind of person that they are. And then the next slide. So this should be 18, I hope. So LGBTQ plus people experience higher rates of suicidality and suicide attempts than the general Australian population. Trans, bisexual, pan, queer and asexual people reported the highest rates of suicidality in their lifetimes. So let's just break that down. So in the general population, just over 1 in 10 people have experienced suicidality in their lifetime. 7 in 10 cisgender people in our community, that's lesbian, gay, bi and queer, have experienced suicidality in their lifetime. Then let's have a look at suicide attempts. So about 1 in 30 of the general population have attempted suicide in their lifetime. 1 in 4 cisgender, lesbian, gay, bi, queer people have attempted suicide in their lifetime. And then the next slide looks specifically at the experiences of trans people. So 9 in 10 trans people have experienced suicidality in their lifetime. 1 in 2 trans people have attempted suicide in their lifetime. 62.4% of trans people reported suicidal ideation, and 9.5% reported suicide attempts in the last year. So that's data coming from 2020. And then is that 20? Yes. Okay. So we'll have a look now at intersectional perspectives. So statistics for LGBTQ, Aboriginal and Torres Strait Islander people are predicted to be higher still. However, formal data is still being collected and stats are usually compounded from stats from, on the one hand, LGBTQ plus people and Aboriginal and Torres Strait Islander people, where in fact there is an intersection there. In August 2023, however, the Walkan Katitjin Rainbow Knowledge Survey found nearly half of the 619 people surveyed who are LGBTIQA plus First Nations young people aged 14 to 25 years had attempted suicide. It's important to indicate the intersections. Individuals might be living with disability, they might be racialized, experience gender diversity, come from migrant, refugee, or other culturally diverse backgrounds, that those are not quantified in the research to date. There is research that indicates mild to severe disability or long-term health conditions impact suicidality considerably. So I promised you we would talk about situational distress, and here we are. So this is a relatively new term that encapsulates risk factors as situational distress. This acknowledges the contextual, systemic, and sociocultural determinants and risks present in a person's life that could impact their suicidality. So that's not what's wrong with the person, that's about what's happening in their world. A situational approach to suicide prevention moves away from support focusing on what an individual can change in their lives to acknowledging the systemic and contextualized factors at play. It's important to distinguish some of these factors will be recurring without fundamental systemic and societal change. For example, for LGBTQ plus people, we emphasise cisgenderism, transmisogyny and heteronormativity as the main recurring situational distress factors. And we're going to talk about those 3 terms in a bit more detail now. So cisgenderism to start off with, it's the social, cultural, systemic ideology of gender experience, identity, expression and bodies that reinforces rigid gender norms. It suggests that trans people, binary or non-binary, aren't real. And pathologizes the trans experience as disordered, among other things. We would also like to make note of the systemic attack on trans women in global media and from individual politicians, and the dehumanizing and transmisogynistic rhetoric that has emerged in mainstream culture. This vilification of women and trans femme non-binary people aims to promote violence toward them. It is a vital state anti-discrimination it is vital that state anti-discrimination protections are rectified and in place. Heteronormativity encompasses a set of societal beliefs, practices and institutions that reinforce the idea that heterosexual and cisgender bodies are natural, expected and superior to other sexualities and genders. It often marginalizes and stigmatizes LGBTQ plus individuals who do not conform to heterosexual norms, such as marriage and child-rearing. It creates an environment where non-heterosexual identities, behaviours and orientations are seen as deviant, abnormal or undesirable, leading to discrimination, prejudice and social exclusion. So to address these recurring situational distress factors, it's important for us to include what to expect from mainstream crisis lines for LGBTQ plus people needing to use them on our website here. Unfortunately, in a major crisis, our communities may continue to face compounding stresses. I'm going to hand over to Sam. Thanks.
Back to me. Thanks, Sam. So the following are recurring situational distress factors for LGBTQ plus people and specific factors for those who are Aboriginal and/or Torres Strait Islander, trans, LGBTQ plus people with a disability or long-term health condition, and LGBTQ plus people from culturally, linguistically and ethnically diverse migrant and refugee backgrounds, and LGBTQ plus people of colour. Many of these factors intersect, and there may be different drivers of distress for specific communities and individuals. Social isolation is a common experience for LGBTQ plus people, but some people experience exclusion from LGBTQ plus communities through discrimination, whether it's racism, ableism, or erasure. Other situational distress includes disconnection from family, community and culture, barriers to gender-affirming care, physical assault and sexual violence, poverty and economic insecurity from marginalization, discrimination, loss of community and social status, dehumanizing policies for asylum seekers, and policies around gender affirmation and recognition, mental health stigma in families and communities, health providers who are untrained to work with our communities, and negative experiences in out-of-home care, nursing homes, aged care hostels, and supported independent living or other disability-related housing. All right, so this is where we're going to get you all in the audience on the other side of the screen there to participate. So having heard what we've discussed already, we'd like you to add what you think, knowing what situational distress factors can impact the lives of LGBTQ plus people, what protective factors would help our communities. So think about what are the protective factors that can be implemented, whether in your organization, at a policy level, just in the social level, however you think. So if you can use your phone, you can go to menti.com and enter the code. You can scan the QR code as well. Excellent. We've already got a good inclusive doctor, connection, inclusion, belonging, friendships, social support, understanding, affirming healthcare, genuineness, supporting community, consultation, inclusive language, a voice, keeps growing and growing and growing. Resilience, safe spaces, listening, power discourse, acceptance, respect, education, compassion. Yeah, I like that. I saw the word fun as well. Pets, great. So connection and acceptance are the main ones in our word cloud. Curiosity is great too. Okay. Okay, that's looking great. I think we can move on. Thanks so much for all of your responses. So the key protective factors which encapsulate all the specific ones you and your everybody included were, we'll move to the next slide. So connections, including connection to community, care networks and mutual aid, connections to culture and elders. Education, including training for services, as well as training for community members to work with peers experiencing distress and to understand how to access services and develop self-advocacy skills. Inclusion, meaning outreach, skills programs, trans and non-binary informed intake forms, LGBTQ+ sensitive translations and interpreters, and community inclusion campaigns. Affirming care, so free, accessible, local, depathologizing, and affirming community-led strength-based services. And protective policies at a state and federal level. Examples include free state-based and run gender-affirming services, inclusive health strategies and frameworks, LGBTQ+ inclusion in the national plan to end violence against women and children, Medicare MBS item numbers to include gender-affirming medical care, including surgery, and everything under the latest equality and conversion practices bills being put forward. Also, decolonization efforts and efforts to dismantle ableism and white supremacy in our society benefit everyone and will help to provide best practice support to everyone. So to dovetail into our panel discussion, it is important to quickly outline the barriers to care that LGBTQ+ people face. In 2019's Understanding LGBTI+ Lives in Crisis report, only 68% of participants in the survey could name one or more crisis support services, and over 71% of participants chose not to use a service during their most recent crisis. So in the next slide, we'll see the following barriers to care for LGBTQ+ people, including anticipation of discrimination, lack of awareness of both mainstream and LGBTQ+ crisis support services, feelings that their crisis isn't serious enough, fears of being outed, not being queer enough. So that's especially for like 5+ people or asexual people. Concerns about confidentiality, concerns about police and medical involvement. While the data reveals LGBTQ+ communities' vulnerabilities within the current systems, we are also adaptable, we use initiative, and we partake in mutual aid outside of clinical care models. In the following panel discussion, we would like to expand on what the real world looks like for suicide prevention in LGBTQ+ communities out there. So I'll just hand over to Sam.
Thanks, Sam. We are up to the panel discussion part of today's webinar. We have about 40 minutes set aside for this conversation, and we are very delighted to have 6 panel speakers who are joining us today. So I'd like them to introduce themselves, and we'll start with Ginny Jane. Here they are, they're all manifesting. So Ginny Jane, can you introduce yourself?
Sorry, I almost didn't unmute myself. Walawari, my name is Ginny Jane, proud Wiradjuri Walbunja woman from the Yuin Nation. I am the Program Manager for the First Nations Health Project here at ACON.
Beautiful, thank you so much. And Naif Jamie, please.
Hi, how's it going? My name's Naif Jamie, or NJ. I'm a suicide prevention peer worker. I'm a queer trans woman, a descendant of the Wiradjuri people. And yeah, I'm happy to be here. I work at ACON.
Fantastic. Thanks, NJ. How about Julie?
Yeah, hi. My name's Julie, and I'm a suicide prevention, lived experience suicide prevention peer worker working in the Bega Valley. Sorry, I don't know. Oh, I'm on Yuin country, and yeah, that's it.
Beautiful. Thank you. Stephen?
Hi everyone, my name is Stephen Scott. I'm the General Manager of Strategy and Policy at Roses in the Ocean. We're a national organisation for people with lived experience of suicide, and I'm coming to you today from the lands of the Cubby Cubby people in central Queensland.
Beautiful. Thanks, Stephen. Max?
Hi everyone, I'm Max Simonson, dialing in off Gadigal country today. I've worked in mental health peer worker roles for over 10 years in the public mental health sector, most recently leading the implementation of Safe Haven Cogra, leading a team of suicide prevention peer workers. I'm also an openly trans man.
Thanks, Max. Jay?
Hi everyone, I'm Jay Gardner. I'm coming from Dharawal land, and I grew up in beautiful Wiradjuri country. I'm currently working in a lived experience role, designated lived experience role at Coordinair, which is the Southeastern New South Wales Primary Health Network. But I've been a peer worker, and I'm coming with my lived experience, my own as a carer and the bereaved.
Fantastic. Thank you so much for all of those introductions. So let's get this conversation going, and I have a hard-hitting question for each of our panel speakers. Luckily, I briefed them in advance. So in 30 seconds or less, tell us your strong opinion on how to respond to LGBTQ suicidality. Ginny Jane.
30 seconds. I've always been a strong believer in lead with love and understanding. I think that, especially from a mob perspective, you know, understanding is one of the most easiest ways to come and be there and mitigate. Is that 30 seconds?
Yes. NJ.
I like to, I think starting from a point of validation and meeting the person, speaking and just being like, thank you for sharing. Thank you for opening up and trusting me with that information. It's very intimate, vulnerable piece of information when someone's sharing that, especially with the power dynamic of clinical frameworks. So I always thank and validate and be like, yeah, it makes sense that you would be feeling that way because of all these things that are happening. And I would probably say, yeah, me too. Yeah.
Thank you so much. Max.
Yeah, I think I'm really passionate about, we need a kind of reform on how we understand suicidality socially, in my opinion. And I'm passionate, I know everything's around suicide prevention and that's the goal, but we're looking at increasing quality of life. And particularly in the rainbow community, there's so much suicide prevention work that happens in the personal time among communities. So what I think we need to do is use the existing skill sets, amplify it, and get that work happening on a broader scale.
Fantastic. I would just like to shout out to how everybody is keeping within their 30 seconds. Jay.
That means I get a bit more time, right? I would say that we see the changes when we recognise that the lived experience is a human rights issue and that our dignity, rights and self-determination is key. So, you know, that means for me that lived experience is the next step of the consumer movement and the leadership of that. And for me, it just begins when we recognise all Aboriginal and Torres Strait Islander people whose knowledge is continually compromised by dispossession and racism, which contribute to high levels of suicidality. So in that, we recognise the social determinants of health and the inherent power inequalities that exist. And I think that's where we start, by just saying that explicitly and then doing something about it.
Awesome. Thanks, Jay. Stephen.
Thanks, Sam. I would say visible, contemporary, community-led discussion about lived experience of suicide run by people with lived experience of suicide. So, you know, pretty much what we're doing right now, and, you know, much more of that. The reason I think this is so important is because lived experience can change our community culture to break the silence about suicide and make it easier for people to disclose their suicidal feelings and find help.
Fantastic, Julie, lucky last.
Yeah, I think to start with, it's so important to connect with the person and to provide a calm and safe space. And that's why I love my job, because that's what we are meant to do. And so it's not the medical model, it's just sitting with someone, being with someone with their discomfort, and validating, as everyone else has said, the lived experience is very important too. And just giving the person a chance to speak in a non-judgmental space.
Beautiful. Thank you. Wow. So you've heard it from everybody on the panel, 30 seconds of power. So now I have some particular questions which will draw on each panel member's professional and lived experience in working in this space. So I'm going to start with NJ. What's a benefit of an LGBTQ plus service like ACON stepping into suicide prevention work?
I think the benefits of having identified roles in general. My previous role was LGBTQI plus identified role in health, and the benefits of that is that it can fast track these peer-based relationships where you can actually authentically start supporting people, because there's that kind of built-in language understanding and communal understanding. And I always would make the joke that my line year did a lot of like the heavy lifting because of all my badges, and you know, the queer kid or the trans kid in ED would kind of relax when they see me, because it's like, oh, you're one of us, it's all good. And I think that, especially with the peer model, sometimes you don't actually want advice. You just want to be with your people. You just want to gather. You just want to talk to someone who looks like you or who's been through something like you. And having identified roles, whatever that identity is, whether mob roles or LGBT ones, or specialist services, fast track that process and also create, I think it's just, it works. I've seen it work so much over time in all these different sectors. So I'm a big, passionate believer.
Beautiful, thank you. And then let's have a look at the flip side of that with Stephen. What's a benefit of a suicide prevention service like Roses in the Ocean prioritising the LGBTQ plus community?
Well, it can only make our work more effective because lived experience is widespread in the LGBT community, as we know. Roses in the Ocean is learning and developing its own capabilities in understanding and working with LGBTQ communities. But we have always had a lot of people from the community involved in the organisation, actually, even from its very inception about 12 years ago now. Sometimes those people have organised into a formal network and run some webinars and so on. But I think that presence of the LGBTQ community in the lived experience of suicide movement tells us that there is something important that's needed here about the naming and identification of lived experience of suicide in the LGBTQ community. So I think there's some very interesting and important synergies there that are still yet to be explored, and it's wonderful to be having conversations like this that are really starting to explore that very interesting and much needed intersection.
Fantastic, thank you. And then Julie, why would people access SPOT rather than go to the emergency department or call 000 in the Bega Valley?
Well, actually, SPOT sort of comes after that. So we usually get people who have called the mental health line, have been triaged, often do come into ED, suicidal or in mental distress, and we see them from that point onwards. So whether they've been whether they've gone into the mental health unit or they've actually still in ED, one of our people will come and see them, and then we'll organise to meet them the next day and continue the support. Spot is an outreach team, so it's sort of it's an acute service, but it's providing continuity of care from the time that the person arrives there. There was another thing that was meant to happen at the same time, and that was the setting up of a safe haven. So that was like a drop-in centre, but more than that, where people could come when they were in distress and not have to go to ED. And when they come there, then there's peer workers and there's also clinicians, but clinicians who have an understanding of, treating people with respect, non-judgmental, in the peer sort of space, really. Yeah, so until we get the safe haven, that will actually be the alternative to emergency. But we do what we can, beyond that.
Fantastic. Thank you, Julie. Okay, so now I am interested to hear some examples from panelists' practice. And I'm going to start with Ginny Jane. How does connection with culture and country reduce suicidality for mob?
Spiritually, as mob, our linear, we are connected to the land in which we come from. That is why we acknowledge country in any of the business that we do. And when we talk about suicidality of it actually happening, we call that sorry business as well. And, with that sorry business, there's still that you go home to the land and you go back to country. With culture and colonization, that has been disconnected. And we talk about that disconnection. It's like a heartbeat. I mean, like everybody's watched the Avatar and how they connect to the lands themselves through their hair and stuff. That's very much like culture. And with our LGBTIQ community mob as well, there's a lot of ostracization with our sexuality. And that's also due to, with colonization came religion, and then that disconnecting with culture itself. And then, so then we find each other in Sydney after Mardi Gras, and we kind of, find love within our own chosen families. And we as LGBTIQ communities as well, outside of Aboriginality, also have that same practice when we find each other and have our chosen families. So for me, I think that when you are accepted, acknowledged, and met with love and heard, that's how we lower it. And that's through a lot of cultural practices that we as the oldest living culture still practice as modern day mob here in Redfern, or Sydney, Gadigal lands. Yeah.
Thank you so much, Ginny Jane. Question for Jay. How does the advocacy work that you're doing with the Australian Bureau of Statistics prevent LGBTQ suicide?
Well, I hope it will. I don't know if the ABS would like me to say that we're working with them, but certainly I'm playing a very small role amongst many to look for some of these changes. Frankly, the exclusion of trans and gender diverse people in population data and therefore suicide prevention data is an act of erasure and, in my opinion, a direct violation of human rights. So we'll start there and try and make some change. I think some of it is acknowledging that the language, like prevention is a strong rhetoric that might be not quite right, and the evidence is often political. I'd like all that to change, but system stuff that I'm working in, I might not reap the benefits from in my lifetime, and I'm 28. So, but what we are doing at the Suicide Prevention Collaborative, which is where I work, the fundamental core is we're trying to reduce suicides in our region and break out of the silos that might prevent us from doing so. Sometimes those silos are our workplaces. So early this year, we had a data workshop looking at the population data and the suicide prevention data, what was missing and what we could do. And just to keep it relevant, I know that we shouldn't separate the suicide death data from people because that really informs advocacy. So we've already mentioned the stuff about applying an intersectional lens and all of that. I totally agree with that. But when I look at the suicide death data that specifies gendered deaths only, I see well-meaning reflections on men's suicide as a national emergency. And then we see the data we saw today. And so for the collaborative, what fell out of looking at our the suicide death data and the population data was a clear advocacy piece that is like, okay, we can impact the 2026 census and the inclusion of gender identity in that. And so, I work together with my colleagues who, I just speak on behalf of them, who had a huge part to play in that, about introducing a submission paper to have that included. And look, I know it's an imperfect system and it's rife with problems, but whilst we are dismantling and reforming those systems, I think people like me who wear a bit more privilege in our community can do some of that hard work of trying to work within it. And I can't tell you how meaningful it was to just sit there in the ABS hearing a bit earlier this month and see how many others nationally put in a submission to have that gender identity and sex characteristics included. So, it's a massive win in my opinion.
Beautiful. Thanks so much, Jay. Keep up the fight. Max, what's an example of how you've used your intersectional lived experience to influence Safe Havens practice in Kogarah?
I was thinking about this question because there's so many elements, and I think for the alternative to emergency departments, for the non-clinical services, they're really new in the last 3 years. We've not had readily available public non-clinical services for suicide, distress, and kind of community engagement. So during our co-design, it was very clear to us in the local community in Kogarah that we needed the service to be able to retain the ability to be anonymous, that people would be able to come in, walk in and get a service without having to give you a first and last name or any kind of like file. Lots of people are concerned about their file, their privacy, and that was something that was really quite difficult to navigate formally, especially with something as high risk as suicide from how our system tends to see suicide. We were able to do that, and that was a really key part for us on the co-design and honouring those commitments to the community. But for people who were in crisis, who needed some support, who wouldn't do that if you took that information, for us, we saw it as a really obvious barrier to a lot of services that you have to give so much information to just be able to get support other than Lifeline. And I guess in that, we also worked with ACON around our data set and how we collect data and the collecting LGBTI data meaningfully in a way that didn't identify people. So we used kind of ACON details that they sent through where people could mark if they were, lesbian, gay, bisexual, trans. We had the gender markers, and it was really lovely to see our data set, because it's one of the only data sets I've seen where I felt kind of represented. Often when I'd have those conversations in research, people would say the data set from trans people was so small, we couldn't include it. So there's just like that erasure that you were talking about. And that at our service, being kind of an openly trans man leading the service and having other gender diverse people on staff meant we were really comfortable with conversations around pronouns, around changing name, and we were able to facilitate that as a team culture so that when people turned up, we knew that that was really important for us to be responsive and respectful. We'd also seen that it had been reflected to me from some parents that had come in that they hadn't seen like a trans person not in an LGBTI service, like something we didn't necessarily expect. They were saying like, they hadn't seen a trans person just existing regularly in the community and being a regular person. And I'd sort of said this kind of like either transphobia or this kind of trans excellence narrative. And we need more stories of trans people just doing really ordinary stuff. And I think so people can see that, someone had said, and I had this view when I transitioned, someone said like, you're working, you're managing a team, you're doing all this stuff. And I think that can be the absence of some of the stories in the media that people can see that you can live a very regular, mostly boring life and just kind of get on with things. So yeah, that was a really key part in our data set, how we made sure that it was inclusive from the beginning. And then also making sure we had really ready pathways into like the P4T, the trans service at ACON, Trans Hub, and just making sure that as a team we were readily resourced. As we weren't a specialty service, we had we felt a responsibility to make sure that we were providing people with really quality existing kind of referral pathways. So luckily ACON has a wide suite of services. So yeah.
Awesome. Fantastic. Thanks so much, Max. Okay, so I have a question which is for the folks who are attending this webinar. This one is for you. Well, and the next one actually. So if you are a service provider working alongside our community, listen up. This question will go to whoever in the panel would like to respond, and it goes like this. What LGBTQ plus inclusive support options are available for members of our community if they're feeling suicidal, they're supporting family of choice, or are grieving a loved one's death by suicide? What's out there? Who on the panel wants to jump in? Max.
The usual physical hand. I wanted to plug in particular all the incredible work that's happened with the Alternatives to Suicide groups and Discharge out in WA. I think the frame of being able to talk openly about suicidal crisis, particularly some of their trans and gender diverse specific online meetings that they have, I think are incredible. They're revolutionary. I couldn't recommend them highly enough. I feel from what I've seen and heard, it's a space for people to be able to connect without the fear of some of the risk protocols or some of the systems type of, police crisis interventions. So I really want to plug Alternatives to Suicide, and they also do really incredible presentations. And I think one of their quotes, looking at the opposite of feeling suicidal, is feeling connected. And I think I tend to anchor in that when things can get really complicated.
Thank you so much. Stephen.
Thanks, Sam. Just building on Max's points there. As an organisation that represents the lived experience of suicide movement, Roses in the Ocean has an emphasis on non-clinical, peer-based services that are delivered in the community outside of the health system, with very easy access, without eligibility criteria, and without those restrictions and coercive practices that are associated with the mental health system. And there's just three components I'll mention briefly here. The first is what we refer to as community-led safe spaces. So these are distinctive from the safe havens that have been developed around New South Wales. They are, as I said, entirely in the community, run entirely by people with lived experience of suicide, of a non-clinical nature, and staffed by trained volunteers who are using their lived experience of suicide to support other people. Now, there's one of those already in Summerhill that's been operating for, I think, a couple of years even now. There's another which has opened recently on the Northern Beaches. And there is also maybe 4 or 5 others that we're working with around the state to have opened. These are very much community-led, so they're run by groups of volunteers in the community who are concerned about suicide prevention in their community. So I would certainly mention that firstly. We also run a phone service called the Peer Care Companion Warm Line. The number is 1800 777 377, and it is a callback service. So it's not a crisis line, but it is a callback service where we peer match people who leave messages with the service with people who have a similar lived experience of suicide. We're currently recruiting many more volunteers into that service as well. So the scope of that peer matching is expanding as well, along with that greater intake of volunteers. And lastly, just specifically for regional New South Wales, we are running an in-person version of that warm line in Orange at the moment. So that's also just started recently, but can be used as a link up for in-person support. So again, we're really trying to provide a range of services here that are entirely peer-based, entirely lived experience run, and that people can access without needing to interact with the health system at all.
Excellent. Thank you so much. Julie.
Yeah, hi. So with Spot, we do provide affirming care for LGBTQ, but really there's not enough in this area. There's not enough support, and it would be really great if ACON could have more of a presence in our area. There's the trouble with the medical and the social side of things as well. There's not enough for people here, social groups, activities. There's one GP that I know of who specialise, well, that's not the right word, who aligns with LGBTQ, and her books are closed now. There should be more. Like, GPs generally are empathetic, but it's not quite the same, is it? You know, it makes a difference when you're with your own people, as has already been said. So it would just be good if there was more. I'm just trying to say visual. So in relation to stigma and discrimination, that's what I'm trying to say. It would be more helpful to promote more visibility of the LGBTQ community within the region with more events and support groups.
Absolutely. Thanks, Julie. Okay, so my next question is, what's one thing that service providers working with our community who are experiencing suicidality, what's one thing that they need to know, the service providers? And I'm going to prioritise the members of the panel who didn't answer that last question. NJ.
What the service providers need to know?
Yeah.
That we're here, we exist, we have been existing since time immemorial, and you are going to get the best outcomes when you believe and respect people. To share a bit of my own presentation cycle, I was coming to ED regularly, and then the times that my pronouns were respected, my chosen name was respected, even though I was at a very day zero of my journey. They're the times where I felt believed, I felt trusted, and I got those recovery outcomes that, the clinical system wants, and it works in the same way that we believe people who come up and disclose DV. We don't need proof, we don't need visual, we believe people, we trust people. And that same approach should be taken to, mob and trans people and queer people and just everyone living at those intersections.
Beautiful. Thanks, NJ. Jay.
Yeah, just building on that a little bit too. I think championing LGBTQIA plus, SB voices means embedding us at all levels of your organisation, or better yet, give up some of the power to community controlled. And I think, why is this important? Anecdotally, and I can only speak from my lived experience. Growing up in rural New South Wales, I was definitely not out in high school. It's a very much if you know situation when it comes to navigating queer identities in rural New South Wales. But during my last year of school, myself and 3 others kind of banded together and really held each other through that messy year of high school for no apparent reason. Obviously, it turns out we were all some flavour of the rainbow. And the reason I highlight this is because, I'm seeing people smile and nod in this panel who are, members of the rainbow family. It's because, in my experience, we've always supported ourselves on the fringes in innuendo and outside of mainstream mental health services because we've had to. So we know a lot about how to help and protect each other and care for each other. So if community controlled were more privileged and trusted more widely, I think we'd be on our way to solutions. So yeah, that would be kind of my say. And if you can't do that, or you don't want to do that, you need to invest in the diversity and build your leadership to be reflective of the population. So yeah.
Excellent. Thanks, Jay. Ginny Jane, what do service providers working with our community need to know?
There's nothing more to add. I think it's already been said. I can't find any more better words than, what I started with, which is lead with love. At the end of the day, I believe that, suicidality comes from a place of trauma, of not understanding. And I've already said it, if we can all just be decent humans to lead with love individually.
Nice. Thank you so much. Okay, so I'm just thinking, are there any last words from the panel before we open up to questions from our audience? Stephen, was that a hand?
Yes, it was, Sam, and I really just want to make an additional comment in relation to your last question there for service providers. LGBTQ sensitivity is a long-term process. This isn't something to just, do a half-day training on and regard your organisation as, successful in this regard. It is a long-term process that must be led by the community itself. As Jay said, what I would particularly encourage service providers not to do is, whack rainbow flags and trans flags on the bottom of your email signature without having done any internal cultural change work, attitudinal change work within your organisation itself. So I would just particularly point to those issues too. Thank you.
Very important points. Thank you, Stephen.
Quickly add to also engage an actual LGBTI service that does the training rather than your trans or rainbow worker that is employed doing something else.
Oh, yeah. Absolutely. NJ.
I want to back that because I think part of the reason I burnt out at my old identified role was being the only person in the village in the big white supremacist patriarchal hospital, and you're being asked to educate and change culture and hold all this space and also be palatable and also be this, but also use your lived experience and it's actually not sustainable. And I think if we start from a point just like we do with acknowledging country, acknowledging the inherent whiteness and maleness, and that these structures actually impact us all and actually make us all suffer under them, not just the people at the margins. And yeah, I think that's a really good starting point because you can't move past something until you acknowledge it.
Most definitely. Okay, well, thank you all so much. I have been seeing questions arriving as well as many votes of thanks and awesomeness. So, hurrah. And I wonder if we might hear from Sam, who I believe has curated the questions for us. Yes,
not so much as curated, but I will read out from the screen. So this is to all panelists. So feel free to jump in if you have an answer straight away. We'll start with this question. It came from the chat. Who was that? So who was that? Let me see. From Sham Ahmed in the chat. How integrated are LGBTQ+ specific community-based suicide care and prevention services to clinical service such as emergency departments, and how can they improve that, or how can we improve that?
So I'm thinking Max and then Julie, perhaps.
From the question, as in the LGBTI kind of specialist services, how are they readily available to the public? So if you go to your local ED, would they have that ready? My experience is it would honestly be in direct ratio to how many rainbow people work in that area, which is a really hard part of this work, that if you have a higher kind of rainbow population in your staff cohort, the chances of getting that information are higher, and it's just kind of inconsistent that it depends on the legwork of people in the community, in my experience. So I think there's been a significant uptake in some of the services, and it's not as simple as just getting word out. I think it's integrating and embedding LGBTI positions within those services to do that, which is a bigger conversation. But yeah, that would be my experience.
Great, thank you. Julie, did you want to add to that?
I just want to reiterate that, because we really do need to have more people from the LGBTQ community within our workforce, even though we do provide affirming care, and it's really important that people get the care that they need, especially, you know, at the pointy end when things are so distressing. But definitely it would make, it's necessary, it's got to happen.
Thanks, Julie.
Yeah.
Excellent. I'll move on to a specific question for Max from Yasaman. How can mental health services make sure data sets are inclusive? Is it possible to contact anyone to ensure we are creating safe and respectful ways of collecting data?
I think it's a tough question that I've asked many times, and it sounds like Jay might be well placed to answer this as well. And I think often the rhetoric that I'd heard was that there was a data set, the government's got a data set for research, and it's male and female, and there's nothing we can do about that. It's really hard to change. That's kind of the classic element. So I think it's a broader conversation around the federal government making a decision and agreement to make changes like that in the data set. I think for us, we were lucky that because we were non-clinical and the way that we collected data was unique, we were able to create a data set which afforded us the privilege of being able to design it to be more inclusive. But I might throw that one over to Jay.
Yeah, I was just reflecting, there's so much in this. Something like the collaborative that we have, being able to share data with each other and members is one of the really key ways that we can start to have really open conversations about what is and what is missing locally. But of course, like we're talking kind of broader levels. Yeah, I mean, we take the steps in the census, we do what we can there. There's just, it's a really big feat, but I think the kind of data custodians that really hoard information and want to keep things in the same way is doing us no favors, and that really we need to apply resource sharing and a kind of more openness to address some of these things. So I hope that's helpful in some ways.
Thanks, Jay. I just wanted to add a historical note, which was that 20 years ago, when I was working in a public health service, we changed our intake forms to include trans and I think intersex back then. I'm not sure. Definitely trans identities. And it was local. We weren't able to change it for the whole local health district. 20 years, people. Surely we can move through this. Stephen.
Thanks, Sam. I just want to add a point to the data discussion that a really important focus for this actually is the state suicide register as well. We've mentioned the census, but in terms of the suicide death data itself, all of that comes through the coronial system, often with the police initially, and then that then forms the state suicide register itself. So the Commonwealth Government, of course, has an important role to play, but the state government, and particularly the collaboration between New South Wales Health and Department of Justice, that's where the state suicide register is created. So I think that is also a really important focus for advocacy as well.
Can I just jump in quickly, Sam? I just wanted to add this tiny part to that is like a lot of the focus of the collaboratives, the local things that people can do. And I would just add that if you're an service organisation, I think the question came through from that way. Yes, these things are really big, like Commonwealth state level. But if you work to co-design your intake and and collect demographic data and how to use that language with the community, then you can internally start really grasping who's using your service, and then use that to fuel advocacy at this level. So I think it does start really locally, and those steps are so important.
Sam.
Okay, so many great questions coming in. I'm just aware of time, so I'm going to sort of piggyback on that data question. Is there a specific organization to address inclusivity in data collection for the government to consult with?
So I think from what people have been saying that there's local, state and federal levels with that. So federally, that would be the Australian Bureau of Statistics, and they have already done some work around including our community in the census. It's just about actually implementing that for 2026. Stephen just mentioned there's the suicide register, but then also thinking about how New South Wales Health Services include us, and they now have a strategy, which I think includes a data collection component. So that would be a really great place to go, hey, let's think about it this way. And then, as Jay was saying, there's the opportunity to look at how organisations collect data at a local level. By all means, co-design with your local community, and that way you'll get the language that people use there. Did anyone from the panel want to chime in on that, or does that sort of cover it? Yep. Okay. Sam, what's next?
I'll move on to this question because it is a very important, I think, question for us to address here. This is from an anonymous attendee. Is there a mechanism or policy for people with lived experience who have been impacted by lateral violence, bullying, rumor mongering, slander, to seek support and assistance? Sometimes the people who participate in the lateral are even people who work in LGBTQIA+ organizations and groups. How can people seek support when they are being dehumanized and purposely isolated?
NJ.
Yeah, this is a great question, and it was something I wanted to bring up as well. I think it's really important to acknowledge that our communities have been doing this sort of work, like chosen family, peer work, mutual aid, for a long time. We look after each other, we look out for each other, we advocate for each other, but also we rip each other apart and tear each other down. And that's lateral violence, and it's happening all the time. And you kind of can't acknowledge one without the other. And it's still happening every day. Like this has to stop before this actually starts working properly. And the problem is that that's on an individual level where people might be practicing care, but also causing harm. And it's like those two things can coexist because people are beautiful and complicated. But we need to be moving towards this as opposed to this, I think, or at least acknowledging both. And that's a really good starting point. Again, just starting from a place of acknowledging that it's even happening, I think is a really great starting point to heal these big ongoing wounds that have been happening in our communities and in mob, like for all time.
Thanks, NJ.
Stephen?
Thank you. I just wanted to add to NJ's points there as well, that I think this is one of the reasons why greater visibility of lived experience of suicide in the LGBTQ community can be so game-changing for us, because as unfortunately, as NJ mentioned, that, you know, we can be very cruel to each other. We can be, you know, very ostracizing of one another. We can have factions and cliques and so on. If we have a greater awareness of the risk of suicide in our community, the difficulty that people may be having with, you know, their own long-term lived experience, particularly of suicidality, we might change our behaviour somewhat and reconsider some of those more exclusionary and callous things that we can do to one another. So I just wanted to make that point as well.
Max?
I think it's also a really difficult part about having kind of a really intertwined community as well. Like the community's kind of, it's not small, but it is small in contrast. So I feel like it can be really difficult if there's, you know, only a couple of people in certain positions, or that the community feels a lot smaller. So there is, we have to acknowledge too, there's also so much pain in the community that activates in different ways. And what is common in minority groups is that people pit us against each other, then we end up fighting ourselves rather than the system. And I think it is a really tricky part of some of this work on knowing who to trust if you have like certain difficulties or conflicts in the area. But I think coming together on a shared kind of mission for where we're heading. And I also think, like, it sounds really simple, but not using like heteronormative or transphobic or like homophobic low blows when you're in a scrap, like having a bit of you can have disagreements and conflicts, but I think I've seen at times that people can kind of lean on those systems that oppress us to their benefit. So I think it's a bit of a shared understanding of how we engage with each other, like Ginny Jane said, kind of leading with love first and focusing on that.
Thanks so much, Max. Sam, I'm conscious of time. What have we got time for one more? Could we sneak in?
I've got one more, and I think this is a great one to end on. How can suicide organizations that cover huge regional areas incorporate more peer roles to better cover small communities within small communities, like the question, the person who asked the question, and cater to the needs of their workers in terms of manageable workload, distance, and travel time? Basically, how do we fill the gaps between, for example, Sydney, Lismore, and Newcastle on the East Coast?
Stephen?
Thank you. I feel like I'm talking too much, so this will be very brief. We have recently done some co-design work of some of the what have been termed universal suicide prevention services under the National Agreement for Mental Health and Suicide Prevention. And one of the things that was made very clear to us by people who live in rural and remote areas was to decentralise these services. So employ and train people in local communities so that we don't have the travel time stuff going on. We don't have, that fly in, fly out approach. So we really need to rethink, I think, the way that we are delivering suicide prevention services in rural and remote areas, and building local community capacity, employing people in their local communities to support their local communities is really the way that we've been, strongly recommended to pursue and to advocate for.
Fantastic. I would just like to shout out to the Rainbow Mental Health Lived Experience networks of the Northern Rivers, and also the Murrumbidgee, who I had the great privilege of working with in Lismore and Wagga, who travelled quite some distance to come along to the 2-day training, and they've then kind of gone on to influence how health services are provided to our communities in those areas. So thank you to those members of the network. Jay, did you have a comment that you were percolating just there?
I was just reflecting, the really transformative stuff we do, I think Ginny Jane said it, it's about our system is working how it's not broken, it's working as it should. And that's because it had never had love at the center. So we start there, and the building off that is, you know, there are a myriad of, like, you know, the stuff that Lived Experience Leadership and Advocacy Network are doing around embedding lived experience governance. It starts with that kind of framework, which I know sounds strange, but if we start to embed people with lived experience at those levels, then we see the changes trickle down to the front line. And that's what, yeah, it's again, I'm a systems person, so that's my answer, but it's definitely not one, it's only one of many.
Fantastic. I think that's a really lovely point for us to wind up on. Stephen. Not Stephen. Sam.
That's all right. Thanks to the panel members. That was a fantastic discussion. Just pull up a slide if I could, slide 34. So just a quick reflection on what we've looked at today. We've discussed experiences of suicide, distress, and navigating care for our communities in New South Wales. The frameworks and gaps in data, recurring situational distress factors, protective factors, and barriers to care, what regional outreach looks like, ways that our communities care for each other already, and what work still needs to be done. Now, speaking of work that still needs to be done, we have upcoming suicide prevention workshops. We've called them Co-Creating Community Care. They are peer-led workshops on LGBTQ+ experiences of suicide. They'll be running from October through to November, in person and online. Expressions of interest are now open. So we'll put that link to that in the chat. So the community care workshops are looking at how we care for each other and establishing a community of care. And workshops 3 and 4 will be empowering your voice and asserting your rights. So everything to do with self-advocacy. And back to you, Sam, as a reflection.
Fabulous. Okay, so as we began, I would just like to remind you that we're all here, and I have really delighted in hearing from my people in both the panel and also questions and comments from the audience. So thank you all so much. So just taking a moment to reflect on what you've heard, what you've been thinking about, what's going on in your heart. Having a think also about what you're going to do this afternoon. I've just had a little blue cat who's jumped onto my desk, so I think she's going to get a little bit of my attention this afternoon. A reminder that there are services available through here.org.au, and I think there is an evaluation survey that will be appearing in the chat or coming your way via the email link that you registered with.
Yep, we'll be following up with links to all the workshops and everything. Yep. And we will be putting all of the information today and a recording video of the panel discussion in an e-learning package that will be downloadable, obviously for free, from the here.org.au website. But we will send out an email to everybody who's attended today and everyone who registered with that link.
Thank you so much, Sam. That's awesome. Okay, so thank you all so much. It's just on time. There are our contact details, or if you would like to get in contact with Sam, myself, or Samara, who's Sam's boss. We would love to hear from you, and I'm really excited to be having this conversation with you all, and I think we've got more work to do. So both at the looking after each other level and also at, changing the system so that it supports us and keeps us here. Thank you all so
Thanks a
much.
lot, Sam.
Thank you.
And thanks everybody for attending today. We've hit 1:30, which is great. I apologize for anyone whose questions weren't read out. Please feel free to email me and also use the suicideprevention@acon.org.au email address that's in the chat now. Thanks everybody.
Thank you.